Hello, I'm going to be talking about inequality in health today. I'm going to talk about current race and health disparities in health outcomes and healthcare access. And we'll talk a little bit about the factors that contribute to those disparities from a sociological perspective, and then explanations for some of those disparities, particularly focusing on race, but also class. I don't think we're going to get to the what about your own health stuff, but the stuff that's important for the exam are the factors and the explanations. The relationship between class and health has been consistently documented for over 100 years. No matter how you measure class or how you measure health, as SES increases, so does good health. Research also shows that even in areas where there is little inequality, those who are better educated or have more money have better health. This is something called relative deprivation. The perception of your class position in comparison to those around you has an effect on your health. This is what the relationship looks like when you graph it. It's so well documented that it has a name, the social gradient in health, or sometimes we refer to it as the SES health gradient. An epidemiologist by the name of Michael Marmot calls it the status syndrome. This is an example of that gradient just presented a different way. So this is looking at the relationship between SES and health among teens. And you can see that poor teens are much more likely to say that their activities are limited or that their health is fair or poor compared to teens who are in families that make $50,000 or more. And that data is from a 2002 study. This slide shows the proportion of the population that is uninsured, and it gives you the racial background of those uninsured persons. So 45% of uninsured people are white, 33% are Latino, 15% are African American. And then the other side of the slide shows you that um, minority populations, specifically African Americans, American Indians, and Latinos, are at a much greater risk of being uninsured given their representation in the population, and also given that the national average of uninsured people is only 18%. This is some data that looks at doctor's visits in the last year, and it's comparing people with insurance and people without insurance. And you can see that having insurance means that you're much more likely to have had a doctor's appointment in the last year. But even among those who have insurance, um, you do see some race differences in uh, going to see the doctor in the last year. So, for example, among Hispanic people who are insured, 21% have not seen a doctor in the last year compared to only 14% of whites. But for African Americans and American Indians, having insurance does make a difference. So their rates of going to the doctor are similar to whites when the insurance is involved. This slide shows those people who have not had a usual source of care. So if you think about folks who have a regular place to go to see a doctor, so you can see that insurance again makes a big difference. So getting those rates of insurance up for uninsured populations is really important. Now I want to look at some health outcomes data because Race and class disparities actually exist when you look at things like morbidity or rates of illness, if you look at preventative health screenings, or when you look at mortality. So here's some data that shows disparities in AIDS cases and HIV deaths. Minorities, in particular Latinos and African Americans, are making up a large number of new AIDS cases and HIV related deaths. Now, a large proportion of those new AIDS cases are among African American women. Minorities generally don't get screened for cancer at the same rate as whites, but you can see that there is some variation here by racial group. African Americans, which are the gray bars on this slide, actually get screened at about the same rate as whites, who are represented by the orange bars. But while African Americans get screened at about the same rate as whites, their cancers are usually detected at a later stage with more invasive tumors. Even when you take those differences into account, they are more likely to die as a result of their cancers. This slide shows mortality rates for the top 3 causes of death: heart disease, cancer, and stroke. African Americans have the highest death rate for all of these causes and the highest all-cause death rate than all other groups. Other minority groups have better rates than whites. African Americans have a higher cancer death rate than white Americans, even though white Americans have a higher prevalence of cancer. So prevalence of cancer for whites is 7.8% compared to 3.4% for African Americans. African Americans have the highest all-cause death rate, and as this slide shows, the highest death rate for 3 of the leading causes of death. They also lead in deaths from diabetes, homicide, influenza and pneumonia, and breast, prostate, and lung cancer. Are the race differences a matter of class? In other words, would the race differences in health go away if we account for the fact that minorities are overrepresented in lower classes? This slide shows that race differences in health status um, at different levels of income are still there, especially for Blacks. So although class explains some of these race differences that we see, it does not make them go away. In this study, they compared Black and white men across income levels to see if disparities in life expectancy were reduced. And as you can see, the gap narrows from a little over 3 years at the lowest level to a little under 3 years at the highest level. But again, those differences are still there, even though they are reduced. This data shows that even when you compare race groups with the same education levels, there are still race differences in infant mortality. African Americans and American Indians have the worst infant mortality rate at all levels of education, but Asians and Latinos actually have better rates than whites. Asians, we would expect because as we have seen, Asians generally have larger income and more education than other Americans. This isn't true for Hispanics. What we see here is what's called the Hispanic paradox, and that is despite lower levels of education and income, Hispanics tend to have better birth outcomes. And there aren't a lot of good explanations for that yet. But one thing that's kind of problematic with this data is that Hispanic, the category, includes a lot of diversity. So you're talking about people from who have ancestry in lots of different places, Mexico, Central America, Spain. So we're talking about a lot of different groups here. This slide shows that people of color, in particular African Americans and Hispanics, are more likely to say that they receive lower quality of health care. So this is one thing that's been pretty consistently um, noted and really reflects the experience of people of color in the healthcare system. And then this study by a guy named Sequist showed that most of the race differences in outcomes that are related to diabetes, so they looked at blood sugar levels, cholesterol, and blood pressure. Um, Sequest found that you could attribute most of the race differences in these outcomes to differences in treatment by the physician. So these differences weren't explained by differences in the patients or differences from one doctor to another, but it was in the way that individual doctors changed the way that they treated patients according to race. So, what all of this information tells us is that at every level of education or income, and taking into account differences in access to care, minority populations have worse health outcomes compared to um, white populations, and lower SES populations have worse health outcomes than those in higher SES um, populations. So, why is that the case? It's complicated, but this is a slide that kind of gets at uh, all of the factors that are involved in health disparities. At the distal level, we're talking about structural issues, poverty, social class, policies, culture, norms, discrimination, those kinds of things. So if you think about social conditions and institutional context in terms of the city where you might live, so what are the policies in that city? What is the poverty level in that city? Those things can affect health outcomes. At the intermediate level, we're talking more about things that might be related to your neighborhood. So the social context of your neighborhood looks at things like what is the social cohesion? How well do you know the neighbors in your neighborhood? Is the neighborhood racially integrated? What's the level of poverty in that particular neighborhood? Social relationships are also important at this level. So what kind of social networks do you have? What kind of social support is available to you? What are the employment opportunities like? And in the physical context is also important. So what is the overall building quality in your neighborhood? What's the level of pollution? Are there parks and recreation available in your neighborhood? Is it clean? Are there businesses there? Do you have access to transit? Are there grocery stores that sell fresh fruits and vegetables within walking distance to your neighborhood? Those kinds of things. And then there are also proximal factors, and those are things that are at the individual level. So it takes into account your individual age and sex and race, your individual risk factors, what kinds of behaviors are you engaging in? And then also gets at those biological pathways that might be important. So, do you have a genetic risk for a particular condition? Do you have a history of diabetes or high blood pressure in your family? Those kinds of things. What we know from research is that the further out um, from proximal to distal that you move, the bigger impact on disparities in health outcomes that you have, because when you move out to those distal causes, you're really getting at root causes of disparities. And that doesn't mean that we shouldn't focus or address proximal factors, those individual risk factors, those biological risks, but it means that we shouldn't focus on just those things. And oftentimes the healthcare system is designed to do just that. So it's not having as great an impact as it could um, by focusing on uh, what we call social determinants of health. But the Affordable Care Act is trying to get at that by actually requiring um, healthcare systems to address those kinds of things. Now, what are some of the explanations for some of these outcomes that we're seeing? Some of the research that's been done really is aimed at addressing the question of why these disparities exist. Um, and studies that seek to explain these disparities fall into one of four categories, and I have them listed here on this slide. And I'm going to talk about each of these and give you an example. And you should just think about being able to explain what each category is and to provide the example for exam purposes. The first model is the racial genetic model. And this model emphasizes population differences in the distribution of genetic variants. So in other words, it really focuses on biological factors. And the assumption here is that race is biological. Um, and it works from the idea that certain racial groups have genetic predispositions that put them at greater risk for certain health conditions. An example of this is the slavery hypothesis. And the slavery hypothesis says something like this, that Africans developed a salt-sparing gene due to chronic salt shortages in Africa. This gene was further selected for during the Middle Passage. As captured Africans were transported to the Americas, those who had the gene were more likely to survive. As a result, African Americans who have this gene retain more sodium, which increases their likelihood of having high blood pressure. The problem with this idea, this hypothesis, is that there's really no evidence that it exists. But there are other hypotheses out there that are focused on this type of model. And it's even led to some drugs being developed that are targeted for um, particular race groups, which is a little crazy, I think. The health behavior model really emphasizes differences in individual health behaviors. So they're trying to answer the question, do differences in health behaviors explain some of the race differences in health outcomes that we see? So for example, do race differences in rates of smoking actually explain the race differences in low birth weight or infant mortality rates? Now, the answer to this particular question is no, um, especially because there is virtually no race difference in smoking between Black and white women. So Black women smoke at about, about 19% of Black women smoke versus 22% of white women. But we do know that if you take a look at health behaviors um, in combination, so if you look at, for instance, physical activity, diet, and smoking, that does explain some of the race variation in outcomes, but not all of it. So there's some support for this model. The socioeconomic status model focuses on the fact that some race groups are overrepresented in lower socioeconomic statuses. So it's kind of the classic, is it race or is it health argument. Um, Most research on this question shows that class differences reduce but don't eliminate race differences in health outcomes, as we saw in some of those slides. But it, again, does explain some of those differences. The stress process is a model that actually came from sociologists, a guy named Perlin, and some of his colleagues developed this model to really explain the relationship between race, class, gender, and age and health outcomes. In particular, they were looking at mental health outcomes. But basically, what Perlin says is that your race, class, your gender, your age, all of those kind of uh, statuses that give us a position in a stratification structure affect the amount and kind of stress that we're exposed to, and also affects the amount and kind of resources that we have available to us. And those things then affect our health. So, for example, if I am poor and my car breaks down, that's a stressor um, because now I can't get to work. I probably don't have the money to get my car fixed, so I have to figure out how to get to work. So I have a lot of stress and not a lot of resources because I don't have a lot of money. But if I'm in a better economic position, if I'm upper middle class, for example, if my car breaks down, then I can probably just get it fixed. It would end up being a hassle as opposed to a major stressor. I could afford to, call a tow truck if my car broke down on the side of the road and have it tied to, or towed to a garage to get fixed. And I might have to arrange to get to work for a couple of days, but it's not going to be a major hassle. As a matter of fact, if it was me, um, my daughter's car is sitting here while she's at college, so I could just use her car while mine is getting fixed. So again, it would just end up being uh, a hassle instead of a major stressor that leads to other stresses. And Perlin says this is the way in which um, our race and our class and our gender, those kinds of things, have an impact on our health. The psychosocial stress model emphasizes stresses that are associated with a disadvantaged status and focus particularly on racism and discrimination. So the stress associated with dealing with things like blocked opportunity and limited resources because of minority status results in wear and tear on the body, both physically and mentally, resulting in worse health conditions. So think about when a person of color experiences a discriminatory act that creates stress and that has an effect on health. So this model is really an extension of the stress process because it's really looking at racism and discriminations as particular forms of stress that majority groups don't experience. An example of a psychosocial stress model is John Henryism. And I don't know if you know about John Henry, but it's a folk tale based on this story about a steel driver by the name of John Henry. He was a really big um, black man who worked as a steel driver. That's a person that drills holes for the railroad um, so that they can lay tracks. And the story goes that steel drivers use 20-pound hammers to drive these holes to lay track. And uh, this guy invented a steam powered hammer to replace steel drivers. And he talked John Henry into participating in a contest to see who was faster, the steam powered hammer or John Henry. And John Henry actually ended up beating the steam powered hammer, but he dropped dead as soon as the contest was over. So he worked so hard, he stressed his body so much that even though he won, it killed him. So, John Henryism is what researchers use to describe a style of coping that's evident in many minorities, but in particular in African Americans, where they are so driven to be successful that they put undue stress on themselves, which has consequences for physical and mental health. And what some of the research is showing is that high levels of John Henryism is bad in and of itself. That can create stress, but it's even worse for health if individuals have limited access to resources or experience blocked opportunities. So if they, um, experience racism and discrimination, and they've already got this style of coping, it really has um, implications for um, health outcomes. More recent studies actually try to combine some of these models. And there's a study, and in the title of the study, it says "Hurt Running from the Police." This study was done by actually a sociologist at Case. Her name is Sue Hinsey, and some of her colleagues. And what they did was combine ideas from the SES and psychosocial stress models. So from the SES model, they take the idea that there's overrepresentation of minority groups within populations that are poor. And then from the stress model, or the psychosocial stress model, they take the idea that physicians and patients kind of have preconceived notions about each other that affect interaction in the medical encounter. So they're looking at this idea of discrimination. And basically, what they found was that um, patients who had socially acceptable characteristics, like they were working, they were a regular jogger, they liked going to the symphony, they were actually uh, prescribed pain medicines more than patients who had what they called stigmatizing characteristics. So, if a patient indicated that they were hurt running from the police or they were recovering from substance abuse, they were less likely to get pain medicines. And it even happened in cases where the patient was suffering from an obviously fractured ankle, for example. Um, and these were all based on scenarios, I should say, not actual patient cases. So they provided physicians with vignettes about various patients and then looked at what factors increased or decreased the likelihood of um, the physician prescribing pain medicine. This is an example of another model. It looks at clinical decision making, and it really illustrates all the points in the clinical encounter where physicians can affect outcomes for all of their patients, and not just patients of color. So, the first part of the model looks at how physicians really should understand that their patients' previous experience with the healthcare system will affect their predisposition, their beliefs, their notions, their expectations about that medical encounter. And that will affect what they do or don't tell that physician, their level of rapport with that physician, those kinds of things. And then physicians need to understand that their patients might not have the same cultural capital as they do. We talked about what cultural capital is earlier in the course, but if patients oftentimes don't have cultural capital that matches that of physicians, and we often use shared cultural capital to establish rapport, to communicate with people. We're more comfortable engaging with people that have the same cultural capital as we do. So that can get in the way in a patient encounter. And then the third thing that this model really addresses is physicians' own predispositions and cultural capital. So it recognizes that physicians themselves need to think about, what is my own cultural capital? What am I bringing into this encounter? What attitudes, beliefs, prejudices, what stereotypes, those kinds of things. What is it about me that I'm bringing into this encounter that might affect the interaction that I have with patients? Um, so those are some of the ways that different folks have tried to explain um, race and class disparities in health. That should do it for the exam. Good luck.